wanted to remind you, if you have questions, please save them to the end, or if you want to type them in, you can type them in the Q&A section or in the chat, either one. And Dr. Kim will try to leave as much time as possible to answer some of your questions. I do want to remind you, however, that every person with lupus is different, and so he may not be able to answer specific questions, but he will do his best. But just want to remind you that he won't be able to answer any specific questions about your lupus, since he is not necessarily your doctor. So I'm going to go ahead and introduce Dr. Kim. Some of you know him, many of you know him. Probably a lot of you are here because Dr. Kim is speaking today. He's one of our most popular speakers and a good friend to the foundation. So Dr. Al Kim is an assistant professor of medicine, pathology, and immunology in the Division of Rheumatology, School of Medicine at Washington University in St. Louis. He's also the co-director of the Lupus Clinic at Washington University. Dr. Kim received his medical and doctoral degree of immunology from Drexel University College of Medicine in Philadelphia. He is board certified in internal medicine. He's a member of the American Society of Nephrology and American College of Rheumatology. He's also on the board of directors for the Lupus Foundation of America Heartland Chapter, and he is a member of the board of directors of the St. Louis Rheumatology Association. If there's anything you want to add to that, Al, feel free, but I'm going to turn this over, and then at the end, I'll pop back on and we can answer some questions.
All right, appreciate it, Amy. I'm definitely not going to add any more to that. That's just fine the way it is. So I want to again thank everyone for coming to this symposia. It's obviously better if we were able to do this in person, but we're still hitting another curve with COVID. The Omicron subvariant BA.2.12.1 is overwhelming the area, and so this is not it's not trivial for patients with lupus. But I think the one thing I want to be able to highlight in today's talk is, while we do know quite a bit more about the impact of COVID-19 on patients with lupus, there are some questions that still remain unanswered, and I just want to make sure that some of the doubt that we have about the impact of COVID-19 is still present for a lot of our patients. And so Amy is absolutely right. I'm just not going to be able to answer very specific questions for each person. Like, what is my particular risk? I don't even know what my own risk is. And so that's kind of where we're still at with some of this. But if you think about where we started a couple of years ago, so now we're about 2.5 years into the pandemic, since its original identification in December of 2019, we do know quite a bit more. And there are some ways to be able to quantify some of this risk for people with lupus. So we're going to go ahead and do a high level overview, but I will show you data, the data that I present to other people, the data that other researchers present to me, because I know that if you're one of my patients, I want you guys to be the smartest, most sophisticated lupus patients, which means that you kind of have to raise that game up in order to be able to talk the talk. All right. So we'll go ahead and, oh, my entire desktop is being shown. Hold on. Let me redo this then. Okay, that should be better. Yeah, my desktop is a mess, so that I apologize for that. Okay. So just as a reminder, the virus itself is SARS-CoV-2. The disease SARS-CoV-2 causes is COVID-19. We often interchange the two in the research world, in the clinical world. They obviously are not the exact same thing. So SARS-CoV-2 obviously stands for severe acute respiratory syndrome coronavirus 2, COVID-19 for coronavirus disease 19. And so this is on the left side, just a graphical representation of what the virus probably looks like. The red are these decorated are proteins that are called the spike protein. We'll be talking about that a little bit more in the talk. And on the right side is a patient with COVID-19. And I think the biggest worries that we have with COVID-19 in people with immunosuppression is the overwhelming the pneumonia and particularly blood clots. Those are really the two main problems that we've had with COVID-19 and well, actually generally, not just lupus patients, but in general. So, there's going to be a lot of questions I'm going to assume. And again, as Amy mentioned, you can put it either into the chat or into the Q&A. I will try to address them in real time. I'll do my best to do that because we should have time to be able to get through everything with a fair amount of time for questions. So, I think in the last talk, there was, some discussions or certainly hints about the feeling of not being counted. Patients with lupus, unfortunately, have multiple episodes a day where you don't feel like you're being heard or being validated. And this is true for all immunosuppressed people when COVID first came out. No one really thought about the impact on immunosuppressed patients. And maybe, simply because everyone was really worried about themselves. Okay, then fine. Then we get the vaccines rolled out. And of the people who wanted to get vaccinated, they were thinking, okay, this is perfect. Now I'm protected. But the reality is that we know from other vaccines like influenza that, there's people on immunosuppression, they don't respond to the vaccines as well as they should. And of course, this puts people at risk because they may be walking around thinking that they're protected, but they're not. And so we've been doing a fair amount of work behind the scenes trying to get the national press to talk about this. I have to give Ariana Cha on the left side here a lot of credit. We were bothering her a fair amount on Twitter behind the scenes. And, she said, this is a problem. And she then was one of the first to be able to put this, she published this article in the Washington Post back in May of 2021. Of course, that's about 6 months after the vaccines were rolled out. So still there was a lag. And then some of you know Ed Young on the right side here. He currently writes for The Atlantic. He's probably my favorite science and medical writer that's out there. He did a really nice piece about the issues that the immunosuppressed people have, especially in the post-vaccine, but right about the time the unmasking of our society started to occur. So if you have access to The Atlantic, in the February 16th issue, Ed has this brilliant piece. It's about 10,000 words. It's a long read, but I think a lot of patients with lupus are going to highly resonate with the words that he says. And he's also a great follow on Twitter. Just as a reminder, a lot of the medical, scientific, and journalistic community we use Twitter primarily as a social media platform for communication. And so I just want to make sure that you're aware that we don't use Facebook, we don't do Instagram when we do, but we don't use it for professional purposes. If you really want information, we are on Twitter, and so as a result, you can get some of the original and truthful comments from trusted sources there. Of course, there's a few untrusted ones, but we can help you weed that out. Okay, 4 topics today. We're going to spend about 5 to 10 minutes on each. First one, does having lupus make you more susceptible to having severe COVID? And this is data that's now about 2 years old. And so we'll be talking about some of those findings in a second. The second one, and probably the one that a lot of people are concerned about, is I'm on medications for lupus. Will it make the vaccine response less effective? All right, a little bit of a complicated answer. So we'll go into some of the nuances here. And then related to that, those 3, can the COVID vaccine make me sick? All right, I'm not saying that COVID vaccines are going to get you COVID. That's 100% false. But whether or not you might get side effects, and obviously some people worry that they flare, right? And so we'll talk about some of the data at the international level. Some of you on the call here may have had a side effect or may have had a flare, and of course, realize that your own experience doesn't always mean that everyone else is going to be the same. And then finally, I'm going to talk about Evusheld. I'm a little bit surprised that more people don't know about Evusheld, and so I want to make sure everyone in the room here is 100% knowledgeable about it and how to ask your physician for it. All right. So first question, and I don't know if Becca could put that poll question. Yeah. So, but this is more out of my own curiosity. How many of you got, or you think you got COVID-19? I can't really tell how many people have answered quite yet, but
Can you see the poll, Al?
I can see the poll question. I just can't see the answers.
Okay,
but
so 40% said yes.
Oh, wow.
48% said no, and 12% said they're not sure.
Wow, that's a fair amount. This is actually a really I would say that within our own cohort, we're probably around 30%. So, again, so a little bit higher in this particular room. Okay, so and the next question here, and the poll question itself will pop up, but I'll read it out. It's how this is now kind of, I know we haven't gone through the data, but I want to be able to put this up just to get an idea where everyone's at. So how much does having lupus increase the risk of needing to be hospitalized because of COVID-19? So this is not talking about just having symptoms. This is talking about symptoms severe enough where they had to go to the hospital. So is it just a 10% increase, which translates to 1.1-fold higher increase, 25% increase or 1.25-fold higher, 80%, 1.8-fold higher, or 200% increase, which is a 3-fold higher? What do you guys think?
Okay, it looks like 14% think 10%, 52% think 25%, 29% think 80%, and 5% 200%.
Okay,
so most people thought it was 25%.
Okay, so the answer is a little bit split. I think in general we do know that it is increased, and one of the most important efforts that allows us to be able to answer this question, and some of you may have heard me talk about this before in prior LFA talks, is the COVID-19 Global Rheumatology Alliance. So this is a massive international effort. It is collecting both physician and provider data along with patient data, and it's put into a large database. And oh boy, over 50 important observations have been made about the association of COVID-19 with anyone with autoimmune diseases through this particular database. So the website is just www.rheum-covid.org. We have representation here locally, with Rima Saeed being one of the site directors for Washington University. So I've been involved with it since its inception. And one of the reasons why I got involved is that some of you know I'm pretty active on Twitter, and the entire alliance and the important observations that were made from it, the entire thing started on Twitter. So again, Twitter is controversial because there's a lot of junk out there. But again, for us professionals, we used it as a networking tool and also a tool to be able to build products. So these are the actual tweets that started everything back in March 11th, 2020. Some of you may know Len Calabrese, who's at the Cleveland Clinic. And he basically saw that the inflammatory bowel disease community was doing something very similar. They actually had started about a week or two before us. And so he then put that tweet out saying, we need to be doing the exact same thing. Philip Robinson, who's in Brisbane, Australia, said that, we have ways to do this. He immediately saw that this was doable. Jinuz Yazdani, who's one of the chiefs of rheumatology at UCSF in San Francisco, said, let's build on this. Philip Seow, who's at Johns Hopkins, then hopped on saying, this is other things that we need to add on. And within about 24 hours, the concept was started, and Genius then on the upper right hand side saying, this is just stunning. We have support from major rheumatology organizations such as the American College of Rheumatology. They already found how they're going to store the data, how to collect the data. And then by March 26th, just a couple weeks after even the inception of the idea, they launched the database, and within that first 24 hours, over 20 cases were already submitted. So right now they are well over 100,000 data points. It's impressive. It's very impressive. Okay, so from that data, there are several things that we have now known in terms of the risk of COVID-19 and its impact on patients with lupus. So in terms of risk of hospitalization, so this goes back to that question I just talked about. For patients with lupus, and again, I'm showing you the data as I look at the data. It can be very overwhelming, I can tell you that. But at the same time, if you just break it down in little chunks and kind of ignore everything else and just pay attention to each line, then certain themes start to emerge. I'm going to, though, help direct you. So the first thing we're going to look at is this line, this fourth or fifth line down, systemic lupus erythematosus. And here what they're doing is compared to patients with rheumatoid arthritis, there is a 1.8-fold increase of people with systemic lupus disease that have higher risk of hospitalization compared to rheumatoid arthritis patients. This translates to that 80%. All right. And so this is actually that answer. Compared to RA patients, patients with lupus have almost twice the rate of hospitalization, 80%. If you look at some of the other ones in blue, so older age, that's a 2.56-fold increase, 250% increase. There are other conditions like hypertension, lung disease, diabetes, kidney disease, like advanced kidney disease. All of these conferred pretty substantial increases in hospitalization. Now, what's interesting is that this is also observed in people without autoimmunity. So having autoimmunity kind of adds on and piles on if other issues that can make people worse off with COVID-19 if they compared to those that didn't have autoimmunity. If you look at the very bottom, you're looking at prednisone. Prednisone is definitely an issue. People, particularly above 10 milligrams a day, this is generally speaking for people with rheumatic diseases. There's a twofold increase, 100% increase in hospitalization rates. Now, what's fascinating and things that we can't always explain, but this is the data, is there are certain medications where this actually decreased the risk of hospitalization. For example, particularly those on TNF inhibitors. So this is not used in rheumatoid arthritis or in lupus. It's not effective, but it's heavily used in people with rheumatoid arthritis and other arthritic conditions. There was almost a twofold decrease in hospitalization, which is fascinating. And so I think, again, we do these studies thinking that we know what the answers are, and largely they confirm. All right. But at the same time, there are some very surprising observations here in terms of, especially those on these, some of these stronger immunosuppressants actually having a protective effect. So again, the answer to this particular question is going to be C, 80%, 1.8-fold higher. When you look at lupus patients only, all right, and the database is large enough to be able to do this so that we can do statistical analyses that give us higher confidence that the answers we're getting are correct. It actually found that anyone on prednisone, not just 10 milligrams a day, but anyone on prednisone had a higher risk of hospitalization. Even if you were on 1 milligram of prednisone, this translated to at least an 86% fold increase in the rate of hospitalization. This is coupled with what's on the bottom right, disease activity. If you have moderate or severe disease activity, that also increased the risk of hospitalization. Now, the problem here is that oftentimes, if you have high disease activity, you're going to need prednisone, right? This is what we typically do for our lupus patients. So these two observations are linked to one another most likely. And so we don't know if it's just prednisone by itself or having more active lupus by itself, or the combination of the two building into each other. So we're still working on trying to figure out where that signal is coming from. The other aspect here for people with lupus are going to be people with cardiovascular disease, particularly hypertension, high blood pressure, and those people with kidney disease. Again, both of these is similar to those patients without lupus. These are two major risk factors for patients with lupus. So if you have lupus and you're on prednisone, you have a higher risk of hospitalization. If you have uncontrolled disease, you have a higher risk of hospitalization. If you have organ issues, high blood pressure, history of a heart attack, or advanced kidney diseases, those also increase the risks too. Now, if you look at medications itself, oftentimes the medications we use in lupus are pretty strong. So we would assume that a lot of our medications would increase the risk of hospitalization. Now, this is true for the ones in the blue here. So people on Cellcept, either mycophenolate or mycophenolate acid, cyclophosphamide, rituximab, these are all associated with increased risks of hospitalization, largely because these are probably the three biggest guns that we have for lupus patients in terms of how much it hits the immune system and kind of renders it unconscious for a bit of time. Now, what was very surprising, though, is that people on methotrexate actually had a reduced rate of hospitalization. It was almost twofold lower. And I think what's most surprising is that some of you may be on belimumab, also known as Benlysta. This actually also translated to a twofold reduction in hospitalization. This is trying to explain why this is occurring is always the most difficult part. These analyses just say A happens at the same time as B. Now, is the A the reason why B is occurring? In other words, is being on belimumab the reason why they have reduced hospitalization? Because we already know that people on belimumab, for example, have reduced requirements for steroids. And I just told you a couple slides ago that having increased steroids or being on any sort of steroids also increases hospitalization. So is Benlysta actually causing a beneficial direct effect in people with COVID-19 infection? Or is it that Benlysta allows lupus patients to be on less or no steroids, which then causes them to have less hospitalization from COVID? We don't know. These are the additional questions we're trying to figure out. But nevertheless, again, these are somewhat surprising. But again, these are the data that we have been collected. In terms of death, we don't have data directly related to lupus. In the registry, there were just not enough deaths in lupus patients to be able to have any sort of statistical confidence. So what ended up happening was that we decided to publish this as just all people with any sort of rheumatic disease. But we were able to break it down on the right side here based off of different types of medications. So the biggest group that we had were people on methotrexate, largely used in rheumatoid arthritis. And then everything was compared to methotrexate. The words we use to describe this type of plot is called a forest plot. And basically it shows you in the dot the average for that group. And then the lines represent kind of the variance or disparity within that group. And so all patients with inflammatory joint diseases, rheumatoid arthritis specifically, and connective tissue diseases in the blue. Lupus is considered to be a connective tissue disease, and it's probably the most common one. So you can see people that are untreated have the highest rates of an odds ratio of almost 4, which means a 500% increase of having death due to COVID-19. Remember, I told you a couple slides ago that having more active disease maybe increases the risks of hospitalization. Not being on any sort of medication, increases the risk that you'll have uncontrolled disease. And so as a result, this may make sense. Sulfasalazine is not used in lupus patients, but interestingly enough, we actually saw also an increased risk of death there. Rituximab, this is going to come back to be a theme later on. Any disease, including lupus, people who are on rituximab, which is a B-cell depleting drug, and again, we'll talk about this in the vaccine stuff, also had an increased risk of death. And again, people on high doses of steroids also had increased risk of death. Now, you're probably sitting there thinking, I'm screwed. I have lupus, I'm on some of these medications, or I'm on some other medications, which just told me I may have an increased risk of hospitalization or death, all right? The issue is that all hope is not lost, right? There are ways to mitigate this, and this is where we're going to transition to vaccination. So this is going to go to the second part of the talk. Do medications reduce the level of antibodies made after COVID-19 vaccination? So we'll have a couple questions here. The first one is, did you get the COVID-19 vaccine? And so I'll go ahead and put that poll question up and give you a couple seconds to answer this.
Okay,
All right.
we have 95% yes and 5% no.
Okay, so most of the people in the room have received the vaccine. The next one, does the COVID-19 vaccine actually work in people with lupus? All right, four choices here, not at all, 0%. Only a small proportion, less than 10%. At least half of lupus patients, 50 to 70%, the COVID vaccine will work for. Or is everyone with lupus who's been vaccinated protected?
Okay, we have the results. 9% said only a small portion. 91% said at least half.
Okay, that's encouraging. That's actually the right answer is C. So I just want to highlight that, some of you participated in our particular study. It's called Coverapad, COVID vaccine responses in patients with autoimmune diseases. But there are numerous efforts, dozens of efforts internationally with over 150 studies that have been published in the past year looking at vaccine responses in people with autoimmune diseases and are on immunosuppression. I'm going to focus on the data generated from our cohort. Some of you may have participated in our study. So these are the data as we reported to the scientific and medical community. Right? And so we have two groups here divided into two smaller groups. We have people on the left side here. These are people that are controls. These are people not on immunosuppression and don't have an autoimmune disease. On the right side are people with what we call CID, chronic inflammatory diseases, which lupus is one of. Within each, you have pre-vaccine, so before the first dose of vaccine, and then post is about 1 to 2 weeks after the second dose of the mRNA vaccine. We were mostly Pfizer in the area, in the St. Louis area when the vaccine first rolled out. We have a smaller percentage that's Moderna. Now, on the y-axis here, these numbers with a 10, 1, 2, 3, 4, 5, 6, this is actually the amount of antibodies that are being detected for each patient. And each circle represents one person. So what you can see here is that if you compare control post versus CID post, is that the CID post people have slightly lower, if you take the average of all of them, have lower antibody responses than people who are not immunosuppressed. It's about 2.5-fold down compared to those people without antibody responses. But on the other hand, the very bottom line, this LOD represents limit of detection. Basically, if you're at that line or below, you don't have any antibody responses. If you're anything above that, you had detectable antibody responses. So while the overall population had a reduction in the amount of antibodies, 90% of the people in our study generated antibodies. So I think that's actually very encouraging because it suggests that the majority of the people who are going to be vaccinated are going to have protective responses. Now, I put this blue dashed line right in the kind of the middle here. This kind of represents the low end of the immunocompetent population, kind of the bulk of them, right? And you can see that in general, about half of our immunosuppressed people with autoimmune diseases are at that line or above. And I think this suggests that minimally, that at least half of our autoimmune population are going to generate protective responses. And actually, I still also think that some of the people below that blue dotted line, we don't know what that line really is, but below it, there's going to be a fair number of those people that are also going to respond. Now, having said that, you know that there's a lot of different medications for lupus. All of them don't impact lupus patients the same way, all right? We're going to start talking about steroids. I just told you steroids are bad for COVID-19. Generally, they're also bad for vaccine responses. We saw almost a 10-fold decrease in antibody responses in people who were on prednisone versus those people that were not on any autoimmune diseases, didn't have any autoimmune diseases and were not immunosuppressed. So this is shown in this graph on the left, where in the far right is prednisone kind of in these grayed out circles. And then the people who are not on immunosuppression in the far left side. So you can see that some people with on prednisone developed really good responses way at the top, and there's a whole bunch of people that didn't make any antibody responses, and there's a whole bunch in the middle. So again, I think this is pretty interesting because we see the wide variety of responses even on people on prednisone. So what we then looked at was, okay, we know that the higher dose of prednisone you're on, the more immunosuppressive it is. So we thought that the higher the dose, the more you're going to have lower responses. We did not see that actually. So again, this is now going to the one on the right side, this graph. We anticipated that people are going to have, on low doses, we're going to have higher dots higher up on the scale, and people with higher doses are going to be closer to the LOD. In fact, we saw numbers all over the place. We saw some people with higher doses of prednisone that generated good responses. We saw some people on low doses of prednisone that didn't generate any response. So this is somewhat similar to the hospitalization data that I showed you for lupus patients as a whole. Our own data within the people that we study suggests that it doesn't matter what dose of prednisone you're on, you are at risk of having poor responses. I did not say that everyone on prednisone is going to have a poor response. All I said was at risk, because you can definitely see there are some people on low doses of prednisone, 5 milligrams or less, that generate good responses above that blue line. And there's actually a couple people on high doses of prednisone that are able to generate good responses above that blue line, okay? All I could do statistically is tell you what's going on if I took everyone and made them the same person, right? And that's what that red line is on that left side. I can't tell you where you would be though along that very diverse response curve that we're showing here, right? So this is the trickiest part about data, is everyone wants to know what their individual risk is. But all I can tell you is that if we took 100 people, what would be the average of those 100 people? And that's frustrating, I get it. Okay, other types of medications that are out there. Some of you may be on MMF or MPA, that's mycophenolate or mycophenolic acid. CellCept is the common term for those. This was a pretty aggressive blunter of a vaccine response. We saw a 20-fold reduction in these people. And again, these are wide variety of type of medications here on the right side. I want you to focus on that MMF MPA one that's second to the right. Again, these are in the dark circles here. Compared to the far left, that's going to be people not on any immunosuppression. The majority of the people had no responses that were on CellCept. Again, there were a few people that did generate responses, and there were a few people that generated really good responses, but the majority made poor responses. So again, we're reporting people that are going to be, if we made them the same person and statistically averaged everything, it's about a 20-fold reduction. We can see that there is some variance, but again, I think the safer way to think about this is that if you are on CellCept, your vaccine responses are probably going to be low. The same thing occurs with B-cell depleting therapies. And the B-cell depleting therapies was by far the biggest culprit in causing bad vaccine responses. We saw almost a 60-fold reduction. Remember, prednisone was 10, mycophenolate was 20. This is almost 60. And this is this BCTD or BCDT, about third from the right here. There were some people that generated good responses, some people that generate modest responses, but almost everyone else had no responses whatsoever. And from a scientific perspective, this actually makes sense. B cells, and the rituximab is a B cell depleting therapy, so it gets rid of B cells. B cells are required to make antibodies. So it makes sense that when you give rituximab to people that gets rid of your B cells, you're not going to be able to make antibody responses, right? But we did want to ask the question whether or not these people that generated responses, why did they generate responses if their B cells were gone? So generally speaking, when you're given rituximab, B cells start coming back about 6 to 9 months after you get your last dose of rituximab. So that's what we looked at here. We saw on the x-axis down here is days since the last B-cell depleting therapy administration. And that vertical dotted line here is about a 6-month cutoff. On the far left, on that left side is going to be on the y-axis is going to be the amount of antibodies, or we call the antibody titer. Generally speaking, the further you are along the B-cell, the x-axis, the more likely you're going to have higher antibody responses. There's better data from both Switzerland and the Netherlands that also show this, particularly after about 8 or 9 months. So people who get rituximab, if you're within definitely a 6-month window, you are most likely going to have poor or absent responses. But if you're beyond that 6-month window, particularly if you're beyond about 8 months, there's a really good chance you will make good antibody responses. Talk to your physician about all of this, because this is going to be an issue moving forward. Same thing with flu vaccines, additional boosters for COVID. They are going to come back. We're probably going to have to get yearly vaccinations, I'm going to guess, for the next few years. This is something that you have to talk to your physicians about, because vaccines are our best bet for protection because of how durable it is. But if you can't if you don't have B cells, because you have to take rituximab to treat your lupus, there's a problem there. Okay, so I just want to make sure everyone's aware of that and talk to your physician about that. All right, so this is, again, almost all you guys got this question right. At least half the lupus population, 50 to 70%, will respond and will have protection from the vaccine. But again, we just talked about this. It really depends on the medications that you're on. All right, so breakthrough infections. These are going to be infections in people who've been vaccinated. Data are still coming in, but some of the first that came from Boston. A couple of our colleagues, Jeffrey Sparks and Zach Wallace, had initial observations in their hospital system, the Harvard hospital system, where they're able to show that people on rituximab, steroids, and CellCept, those are the top 3 medications where they found that breakthrough infections occur the highest. All right. So again, this is all making sense that the antibody levels that you're generating, there's going to be probably some correlation with the ability of your body to be able to fight off a COVID infection if you happen to be infected. All right. So again, these data are still coming in, but there's early signs that the antibody levels may be predictive of that. Let's say you have low antibody levels. I'm not saying to check them, because the tests are all over the place, and we don't know what level of antibody is needed in order to get a protective response. All right. So I don't want you to be walking around thinking either you're not protected or you are protected because you got an antibody test. I don't think those tests tell you that. Okay. But what I can tell you in the research world is that if you get an additional dose, here we looked at 3rd dose, you really make your antibody responses much, much better. Right. And so one of the things that we are always worried about are these new variants. When we looked at this probably about 8 months ago, Delta, which is the far right one, the B.1.617.2 variant was going around. And we had some people before that 3rd dose that had really, really poor responses to either the common variant, the beta variant, which is in B, or the Delta variant in C. But all of those people, once you gave the vaccine, the 3rd dose, all of a sudden their responses blossomed. All right. And that's the benefit of these people of having additional doses of vaccine. And again, these are immunosuppressed people. These are actually RA patients on TNF inhibitors. And so we know that there's some blunting of those responses, as you can see on the left side. But again, they blossomed after getting that 3rd dose. So getting a boost for most people is going to be really effective. So Gene has a question. Would you consider people with kidney functions between 50 and 59 to be chronic renal insufficiency, but 3 times? So this is more severe. So this is, I believe, we consider GFRs of 30 or less to be, and we don't consider race anymore. We got that just got deleted from the standard equations for calculating EGFR, estimated glomerular filtration rate, which is a surrogate of kidney function. Generally, most people are born with EGFRs of greater than 90. As we age, we'll go down into the 60s to 90s. And if you have intrinsic kidney disease, or you have things that threaten kidney function like high blood pressure, it can drop below 60. So the people that were at the highest risks, they were generally below 30. All right, so it's pretty advanced kidney disease. Good question. All right. Okay. So we just talked about the issue about having getting the booster and that being beneficial, but the B cell depleted people, again, boosting when you don't have B cells, guess what? It doesn't always work. So again, this is a beautiful study. This is from Norway, where they took a whole bunch of people, 49 people who were on B cell depleting therapies, who had junk vaccine responses. And you can see that on the left side, second dose. All of these dots are below this dotted line, which is kind of what they're estimating is a protective threshold using their particular test. And then all of them got a third dose. You can see that a small handful of them were able to increase their titers, all right, increase their antibody levels. Almost the rest of them, all right, of 75% of them were unable to be able to get a response, all right? So they then looked at people on the right side here and how far away were they from that last rituximab dose. And what they found is that people who had good response, had any response, they were at least 8 months out. Those with no responses, they were at 6 months out, all right? So again, the timing of rituximab and then when you get vaccinated is going to be absolutely critical. So generally, we've always tried to get our rituximab infusions done in September and October because the flu vaccine came out in November and they usually get in November or December. We're going to have to think about that same type of timing for any subsequent COVID booster vaccines. All right. So I think this is something that we still need to work into our kind of clinical workflow for our patients on B-cell depleting therapy. So Katie has a question. Do you anticipate a time where we'll be able to test antibody levels and know whether a booster is needed or you are protected? No, I don't. And the reason why I say that is because there's so many. The type of tests that we typically have out there are going to be testing antibodies that just bind to that spike protein because that's what we're immunized against. It's actually only a small subset of those antibodies, what we call neutralizing antibodies, that actually block that actually bind to the spike protein so that that virus can't infect other cells anymore. So basically it kind of is a cap over the virus. And as a result, the virus just sits there and just eventually disintegrates. So the tests to do neutralizing assays are really technically difficult. All right. So, for example, here at WashU, the way we've been able to do it is we have a colleague named Michael Diamond, who's a world-class virologist, but he has a facility here where he can use SARS-CoV-2 virus, but it has to be under high security. These people have to literally be put into spacesuits in order to work with the virus and then be able to do the experiments for us. If that became a commercial assay, it would probably cost about $15,000 per test for the patient to pay, right? It is so hard to do these assays. I just don't think getting your antibody levels checked actually is really helpful. There's a big debate though amongst physicians, but I personally think checking antibody levels is not helpful. Do you suggest a booster dose for those people with lupus? If so, when? We can let's hold on to that question at the end because again, there's a lot of nuances to that. Okay, let's wrap up a couple things. We're running actually a little bit behind. Will I get sick if I get the COVID-19 vaccine? So a couple questions here. Fifth question, what proportion of people with lupus get a side effect from the COVID-19 vaccine? No one. Everyone goes through it without a side effect. Only a small proportion get a side effect, less than 10%. At least half of lupus patients get a side effect, 50 to 70%, or everyone with lupus gets a side effect with a COVID vaccine. I'm curious what people think here.
Okay, Al, we have the results. 24% think only a small portion, and 76% think at least half.
Okay, all right. Let's change the question just a little bit from side effects to flares, right? In other words, yeah, you're all of a sudden your lupus is under good control, but then you start having the same symptoms of your lupus flare after vaccination. So this is different than side effects, at least the way physicians think about this. Flares is going to be a repeat of the symptoms that you get with your lupus flare. Whereas if you get other side effects, that's more, or other symptoms after vaccination, that we consider that a side effect. So is it no one, a modest proportion, let's say 25% or less, at least half of lupus patients, 60 to 80% will flare, or everyone flares with lupus if they get a COVID-19 vaccine?
Okay, it looks like 4% think no one flares. 74% think only a modest proportion. 22% at least half.
Okay. So we got some smart people in this room, because the majority of the room got the answers correct. So there are data in lupus patients specifically looking at side effects here. So there's a study from NYU in New York City. This one, the table here is from Strasbourg, France, and then there's another study from Peru. So here, what you're seeing are going to be the top two is going to, or top two of the top three: side effects after first vaccine dose, 45%; side effects after second vaccine dose, 53%. In the NYU cohort, they had a 71% adverse event rate. And then the Peruvian study was 92%. So this is interesting because everyone's measuring these side effects the same way. But why are we getting such different responses? I don't really know. I think it's really fascinating. But if you look at the, this is actually another study from the Netherlands. If you look at these people, so you can see that on the y-axis is the percentage of people with side effects. And then on the x-axis is going to be the type of side effect. And you can see that the most prominent side effect that people have is pain at injection site, right? About 83% of them had pain at the injection site, which is actually lower than I anticipated, because you're going to be getting a needle and that hurts. All right. So actually 17% of the lupus patients had no pain when they got the injection with the vaccine. But then the nuance here is going to be the different colors within it. So the light kind of almost whitish gray color is going to be mild side effect. Darker gray is going to be moderate. Even darker gray is severe. And then the black is grade 4, where there was a need for hospitalization. So you can see that the majority of these type of side effects are mild. And this is largely true for almost all of these side effects. The exception of fatigue. Fatigue was the second highest. Is about 75% of people with got fatigue after the vaccine. And it was split largely between mild and moderate. But you can see the remainder are generally less than 50%. And the majority of those people, though, still had just mild symptoms. So numbers all over the place, anywhere between 45 to 92% of people will get a side effect. But again, most of these are moderate or mild. What about, and so as a result, most of you guys got that question right. What about flares? And again, this is data from the Strasbourg, France group. So here, they only reported a 3% flare rate, which is quite low. The hospital special surgery, which is also in New York City, had an 8.1%. The NYU cohort in New York City also had a close number, 11%. Peru had the highest, 27%. One could argue that maybe the medication use in the US versus France versus South America might be different, and they are. We don't know if that's the reason why. But in general, flare rates for the majority of the studies are about 10% or less, with some studies in the higher teens, and in Peru's the highest at 27%. So generally speaking, for question 6, only a modest proportion of these people will flare, and that will be B, which most of you got. Okay, wrapping up the last couple slides with Evusheld. If you don't know what Evusheld is, you need to know what Evusheld is. If your physician doesn't know what Evusheld is, your physician needs to know what Evusheld is. This is probably the most important mitigation action that we have for people that are at high risk of poor vaccine responses, i.e. people on B-cell depleting therapies, people on CellCept, people on steroids. So what is Evusheld? It's actually 2 antibodies that highly effectively block and neutralize SARS-CoV-2 virus, similar to the type of good antibodies that you would make after vaccination. The 2 antibodies have awful names: Tixagevimab, cilgavimab. And then this is more for the techies in the room, particularly the physicians in the room. I think one of the most important things here is that the half-life of this antibody is almost 90 days. Most antibodies have a half-life, in other words, it goes from 100 to 50 to 25 to 12.5 every month. Here, it goes down at that 50% rate every 3 months. So this is really a long-lasting, durable type of antibody that can give you long-lasting protection. And the reason why that's important is that this probably protects people, if you get Evusheld, for a good 6 months, if not a little bit longer. It was granted for EUA authorization was granted for use for this as pre-exposure prophylaxis, something that we call PrEP, back in early December. It's a broad use of indications. It's also can cover the adolescent population. So people who not infected, but have some sort of immunocompromising condition, they are higher. You are eligible for this. The EUA lists specifically the type of medications and conditions that are eligible. Everyone with lupus is eligible, with only one exception: people just on Plaquenil. If you're just on Plaquenil or you're unmedicated, then you're not eligible for Evusheld. Most likely you don't need it, all right? And the other thing too is that there's no utility for testing antibodies because, again, like I told you before, the tests are all over the place and it's really hard for me to interpret. Another key aspect: you cannot get Evusheld if you choose not to get the vaccine. This is different from those people who have a side effect from the vaccine that prevents them from getting another shot. All right. If you had a bad side effect from the first shot, I have not forced my patients to get that second shot because I know I could just make things worse. Right. Evusheld is still you're still eligible for Evusheld. But if you believe that the vaccine doesn't work and you're not going to get it, or for whatever reason you don't want to get the vaccine, unfortunately, you're not eligible to get Evusheld, right? You really have to do vaccination first as that initial attempt, and then you can get Evusheld afterwards, all right? Side effects, generally very low. We're talking, less than 5% in general. Headache, fatigue, cough. We've been giving hundreds of Evusheld in our clinics here. No one's had any significant side effects. People with heart disease had a slight increased risk of other heart issues going on, 0.6%. Talk to your physician about this issue. We have given it to people with prior heart attacks. I have not seen any issues that wash you. All right, final take-home lessons, then we'll address some questions. People with lupus are at higher risk of hospitalization and severe COVID-19 compared to those who are not immunosuppressed, particularly those people that are on B-cell depleting agents like rituximab. Most people with who are immunosuppressed and have an autoimmune disease, you guys will mount vaccine responses. That's not the issue. But there are certain medications that put you at much higher risk of having poor responses. Those B-cell depleting agents we just talked about, that mycophenolate or CellCept, steroids, and then everything else is much, much more modest. Side effects are common, but they're generally mild, all right? And it's almost related to that injection site pain and fatigue. And then last point, even if you think you got good vaccine responses, you are still eligible for Evusheld. Get it, all right? This is also effective against the current subvariant that's coming around right now, that BA.2.12.1, that Omicron subvariant. So this allows you to be able to, guarantee that you have that type of protection, so you don't have to worry about that first point. Okay, I'm going to answer this other question here that Kyla had put up. Again, do you suggest a booster dose for those with lupus, 3-dose series completed already? If so, when? The answer is yes. I would wait about 4 to 6 months after your 3rd dose to get the 4th dose. And that's true for everyone else. Again, if you tolerate the vaccinations, and not everyone does, we just went through the data. If you tolerate it, I would get the 4th dose of vaccine, and I would still get Evusheld too, all right? It doesn't hurt to get it. How you get Evusheld, your physician should know. It's different in Kansas than in Missouri. In Kansas, basically each county has set up a site to get Evusheld. In Missouri, it's largely concentrated in major hospital centers. So for example, in St. Louis, Barnes, SSM, Mercy, I believe are the 3 sites that are giving Evusheld, and everyone just kind of gets funneled to one of those 3 sites. Obviously, if you're a patient in the WashU Lupus Clinic, you'll get your Evusheld at WashU Barnes type of thing. So, but talk to your physician. How long do you wait for the 4th dose after getting Evusheld? You have a fair amount of time to wait, right? Because it's protected for at least those 6 months. So I would probably do it, no sooner than maybe 3 months, 2 to 3 months, if you really wanted to get it that quickly. But again, you have time. You have time after you get Evusheld to get that 4th dose. All right. So that's, I think, a really important point to hammer home.
We are a little over time, but and Dr. Kerr has said she's okay with that.
All right, thank you, Gail.
So we can answer just a couple more, and then we do need to move on to Dr. Kerr. Do you want to answer that one, Al?
Let's see. Yeah, you mentioned Plaquenil. How much does that impact the chance of severe COVID? 0, right? We made a huge stink of this in early 2020. All right. Didier Raoult was the pseudo-virologist in France that had that data suggesting that Plaquenil was protective against people with COVID. It prevented severe COVID. In his study, though, people that went to the ICU or died were excluded from the analysis. It's fraud, right? So, and there have been numerous phase 3 large clinical trials that showed that Plaquenil has no effect on COVID.
Any other questions?
Do you recommend 4th dose, then Evusheld, or vice versa? I would just get Evusheld first, probably, because that's, part of the issue here is whether or not additional federal funding for COVID related products is going to be extended. All right. It doesn't look like it will, which means that, we have many more doses of vaccine than we do of Evusheld. And so if the government funding runs out and the hospitals then have to buy Evusheld, then they have to bill your insurance company, then you have to get a copay. Right now, if you get Evusheld, everything's free because the government paid for it already in advance. So I would get Evusheld. This is more of a practical reason. I would get Evusheld first because there are more limited supplies of that. We have vaccines everywhere, all right? And so go ahead and then you can wait for the vaccination later.
There's another one. I got Evusheld last month and haven't had my 4th shot yet. When should I get it?
So we just covered that, right?
Okay.
And the last 2 questions. I would wait a couple months. You can wait, 4 months.
Okay, I think we're going to wrap up so that we can get to our next presenter. So if you have other questions, you can shoot them to us, and we can see if Dr. Kim can answer those offline. So thank you again, Al,